Well, welcome everybody to this next in our series of sessions looking at advocacy and personal health budgets and other health funding support processes. We're really pleased to welcome Janet Blair, who is the mental health lead in the PHB team at NHS England, and Bonnie Studd, who is the personal health budget manager at the Advocacy Project in City and Hackney. Have I got that right? Hope yes. So this session, we're really going to be focusing on Section 117 Aftercare and personal health budgets. As I said before, we'll be using the chat box and the question and answer boxes. So please do put your questions in the Q&A and any other chat, feel free to message us in the chat box. The chat box automatically sets to send messages to hosts and panelists. So if you want to raise questions with the other people who are attending the session, you need to change your settings to everyone. Okay. All right, Janet and Bonnie, I'll hand over to you. I'll turn my camera off and I'll mute myself, but I'll be here if you need anything.
Great, thank you very much. So as Gail said, my name's Janet Blair, and I work at NHS England within the personalised care group and specifically within the personal health budget team. I think you've had colleagues of mine come and talk about personal health budgets in a previous presentation. I focus primarily on mental health, personal health budgets and personalisation within that setting. I have a background as a mental health social worker with experience in adult and CAMS, children and young people's mental health services. And Bonnie works within as a partner to City and Hackney. Bonnie, do you want to just explain to people your role there?
Yeah, so I'll go into a bit more detail about our service when I talk through some of our case examples. But yeah, so in City and Hackney, personal health budgets are offered as part of the mental health recovery pathway to people living with a severe and enduring mental health condition that are receiving support from the local trust. And also sort of like involved in the work that we do in City and Hackney. We are sort of involved in the mentorship scheme with NHS England, so kind of work with Janet and some of the other personal health budget services across England to sort of support and give a bit of advice and guidance around what we do in our local areas.
So our email addresses are there. So if after the session there are things that you come across that you want clarification of, by all means get in touch with us, because we're not anticipating that we'll cover absolutely everything today. But if we can move on to the next slide, it'll just give you an idea of what we hope we're going to cover today, which is basically I'll do an introduction to personal health budgets within mental health. Just to help you understand the context for extending, we have a right to have for people who are eligible for Section 117 Aftercare. So we would work with people, within any mental health setting, and there are personal health budget offers across the country, such as the City and Hackney one, that aren't focused specifically on people who have the right to Section 117 Aftercare. But within the offer, people who have the right are being offered personal health budgets. So I'll focus a little bit on that and explain the context for it, and introduce you to Section 117 Aftercare and the guidance supporting the right to have a personal health budget. A bit later on, we hope to show you what good looks like. Bonnie's got some lovely case examples, and there's some from other parts of the country. And then we'll focus in on some of the common frustrations and the routes for challenge for you as advocates, and end with some support available. And as I understand it, these slides will be made available, if they haven't already, to everybody who's shown an interest in today's presentation. So if we could have the next slide. Thanks, Bonnie. So this is really the timeline for the right to have in a personal health budget. So I'll refer to PHBs, and please do pick me up if I refer to any other acronyms that don't make sense. So since October 2014, adults who are eligible for continuing healthcare and children eligible for continuing care have had a right to have a personal health budget. There was a national pilot between 2009 and 2012, and in a minute I'll provide you with the link to that and the findings from it. But basically that started people to think about, well, where else would a personal health budget be able to benefit people? And in 2018, all clinical commissioning groups, CCGs, were informed that PHBs must become the default operating model for everybody in receipt of adults continuing healthcare, and that would be implemented as from April 2019. At the same time, in around about early 2018, a national consultation was held looking at extending the legal rights to have a PHB to other groups, and included in that were people eligible for Section 117 aftercare and people who were eligible for personal wheelchair vouchers at that time. That national consultation led to it being agreed that we would pursue the right to have for Section 117 aftercare and for personal wheelchair budgets. So there are 4 areas of right to have at the moment. In early 2019, the Department of Health announced that those would be the 2 areas that would be pursued as right to haves, and I'll explain why in a moment. And then on December the 2nd, 2019, that right to have came into effect for people who are Section 117 aftercare eligible and for people who are entitled to personal wheelchair budgets. Now that came into effect, as you can see from the date, around about the same time as COVID started to impact. And so it's been fairly slow in some areas. The work that we'd anticipated doing last year was very much focused on highlighting the right to have and working with clinical commissioning groups to develop the mechanisms for that. But obviously COVID has had its impact, and we'll talk a bit more about that when we come to some of the common frustrations. I said earlier that we had undertaken a pilot for personal health budgets between 2009 and 2012, and there was an evaluation that took place alongside that national pilot where sites were implementing personal health budgets in a wide range of settings, not just mental health, right across physical health. But one of the central findings of that pilot evaluation was that personal health budgets improved quality of life for people, and also resulted in a reduction in the use of unplanned hospital care, because people were better meeting their needs in the community. They were using unplanned hospital care, emergency services, A&E much less frequently, and much more appropriately in terms of their needs. And benefits were particularly evident for people with mental health conditions, those with high levels of need. And what became really clear as well was that for those sites that were implementing with people with higher levels of need, personal health budgets were noted to be cost effective, because again, people were identifying their own needs and then being able to meet those needs in the most cost effective ways. And that's the link to the PHBE report that went alongside the pilot. You can move the slide on, thanks Bonnie. So every piece of work that we've done since that first evaluation report has basically found the same things, that where people are being offered personal health budgets, people are reporting improved health, well-being and quality of life outcomes, and benefiting from the ability to live in the community with tailored support. This is a link, if you go onto that NDTI reports, the underlined bit, this will take you to the National Development Team for Inclusion report that was undertaken with staff and people who received budgets in City and Hackney and in Birmingham. And staff in particular reported on improved job satisfaction thanks to an ability to work much more creatively with people. It resulted in improved morale, job satisfaction from just seeing the difference that personal health budgets could make to people, and all the information, detailed information from those 2 sites will be available if you go into those reports. We also noted, as we were doing closer work with City and Hackney and Birmingham and some other sites, was that people from Black, Asian and minority ethnic communities in particular seem to be using personal health budgets to meet their needs in really creative ways. And so we went out to tender, and the Race Equality Foundation undertook some work, which is the link there, phase 2 report, where they went back to those sites and to other sites and liaised with clinical commissioning groups and voluntary sector organisations up and down the country. And if you look at the beginning of that report, they've done a lovely little chart which shows, the impact that they feel that personal health budgets have had for those people, which basically, the upshot is that when done well, personal health budgets were shown to be a life-changing support option for people from those communities to enable them to manage their own well-being in the community. If we could move on, please. So the work, as I said, in City and Hackney isn't focused specifically on people who are Section 117 aftercare eligible. It's offered to a wide range of people who are in their recovery pathway following mental health conditions and moving back towards, living in the community. The reason why, when we looked at doing the consultation, we talked about Section 117 aftercare, was because it has pretty much, the same or similar aims as personalisation, which is to help maintain people in the community with as few restrictions as necessary and wherever possible. And the quotes from this element of the presentation comes from the Mental Health Act Code of Practice, which if you go onto that link there, it will take you to, I hope, it might take you directly to chapter 33, but it will take you definitely to the Code of Practice, where it has a chapter on Section 117 aftercare. So the definition of aftercare allows people to develop a more personalised approach to meeting their health needs. It encompasses a wide range of needs that people may have, including not just healthcare, but social care, employment services, supported accommodation, and services to meet the person's wider social, cultural, and spiritual needs. That's the only proviso, is that those services procured must meet a need that arises directly from or is related to that particular person's mental disorder, and helps to reduce the risk of deterioration in the person's condition. So Section 117 aftercare is a really clear definition of, what it hopes to achieve, the kinds of areas that people might focus on when they're thinking about care planning for themselves within the community. But there is this proviso that it must meet a need that is directly related to the mental health disorder or risk of deterioration. If we can move on. The other thing about Section 117 aftercare, which is unique in terms of mental health services, I think, is that eligibility for Section 117 aftercare is really clear. And this is basically the eligibility. It requires clinical commissioning groups and local authorities in cooperation with voluntary agencies to provide or arrange for the provision of, and this is free aftercare, to people who have been detained in hospital for treatment under one of these sections and who then cease to be detained. So anybody who has been detained under Section 3 or one of these other sections, which are often referred to as forensic sections, would automatically become eligible for Section 117 aftercare, and would also be eligible to be considered for a personal health budget. Now, when we first started this work, we assumed that would mean that funding would be easily identifiable, because mental health aftercare services must be jointly provided or commissioned by local authorities and clinical commissioning groups. They should be keeping a record of everybody who is Section 117 eligible, so there should be a register in every area, every clinical commissioning group area, local authority. There should be a list of people who are Section 117 eligible. As we know, lists are, and it's not unique to Section 117 aftercare, lists are always difficult to maintain. And And that's one of the things we often say to people is if they're looking at providing a personal health budget offer specifically to their Section 117 aftercare population, then that's what they need to get up to date in the first place. Just make sure they understand who is available, who is eligible. And here I've just added this rethink leaflet on Section 117 aftercare. If you want to go and read more about it afterwards, the lovely leaflet that explains exactly what it is and who has eligibility for it. If you could just move on, please, Bonnie. And I just wanted you to be clear about the different sections. I'm aware that some of you on the call will be IMHAs and probably already know this, but for other people, they may not. So Section 3 is a treatment order, which can last up to 6 months. And then the other orders here, as I said before, are commonly known as forensic orders, because they'll be issued through court proceedings or when somebody's been sentenced or is waiting to be sentenced in a prison setting, but clearly has mental health needs and needs to be transferred to a secure mental health setting. If you could move it on, please, Bonnie. I mean, that was just a little overview of Section 117 aftercare and why we have focused on that.
There's a couple of questions in the chat, Janet. So one question is asking, does it matter how long ago a person was detained?
No, somebody has to be formally removed from Section 117 aftercare. So, and it would need the local authority and the health provider. Usually, the clinical commissioning group would, refer to a doctor. So within the mental health trust, and they need to be in agreement that person can be removed from Section 117 aftercare.
Thank you, Janet. So another question asking or saying that that is related to guidance isn't very clear, and somebody else saying that they're working with someone who's eligible for Section 117, but the local authority is saying that some of their needs are outside scope and fall under the Care Act and not Section 117.
I mean, this is, this. I think I was an AMP previously, and these are points of law that often, get argued about, and often you'll find that people will be, in hospital waiting for months, ready for discharge, but caught between a rock and a hard place as the local authority and health argue whose responsibility this person is. Section 117 aftercare itself is a very complex area, I think, of the law. There's some guidance specifically around whose responsibility somebody is if they're Section 117 aftercare that covers a number of years. I haven't put the link to that actually, but I'm happy to provide that afterwards, Gail, if people would want to see it. I mean,
I think that would be helpful.
Clear as mud, but it basically goes back over the years, because often a person can be have become Section 117 aftercare eligible, 30 years ago. It was introduced in the 1983 Act, I think, and may never have been removed, and they may have moved around the country in those times, and so people, I see somebody's asked in which circumstances should an individual be removed, and that, again, that's very, it's rare for people to be removed. I think one of the most common things is that people don't actually understand that they are Section 117 aftercare eligible in the first place, and so they never ask about it because they didn't realise it's not something that is perhaps well explained to people. And when people are coming out of hospital, maybe they're not 100% well anyway. So even if it was explained, wouldn't necessarily remember it. So like I said, it has to be an agreement, because it's a joint responsibility between the local authority and health. So the CCG has to agree it, and usually they would defer that to a doctor's opinion. And they need to be, it's written in, if you look in chapter 33, it's written very clearly that they need to be in agreement that the person's mental health isn't likely to be affected or deteriorate if they are removed. And there are instances, I mean, you know, of people who are in that situation and, you know, would want to be, you know, removed in that, you know, that there are people who come through mental health services and move on with their lives. But obviously it's a difficult decision to make if you're faced with people who are saying, actually, no, I am going to become more unwell. Sorry, I have to say, I just come back to work from a period of I had coronavirus, so some of my brain's not functioning quite as fast as it has done. But there is also a Pan-London guidance around Section 117 aftercare, which I haven't got the link into here. But if you can collect up the things that I'm saying, I will send Gail. I'm more than happy to send the link to that as well, because it's really helpful in that, you know, a lot of places have been very nervous about removing people from Section 117 aftercare because, you know, they're worried about judicial review and it all going, you know, getting challenged. I mean, the reality is that if you remove somebody, you would normally be doing that, you know, in consultation with them, should be doing it in consultation with them,
yeah,
and in agreement. And also, I think if you look at chapter 33, you'll see that there's a period of time within which if somebody is removed and then their mental health starts to deteriorate, they can be put back on to Section 117 aftercare. But the guidance, the Pan-London guidance, has a really nice little form, and it talks you through how you might remove somebody from being eligible within it. So
Janet, there's two other kind of technical questions, and it's about the kind of role of the local authority and the CCG. So one says, what determines whether it's the local authority or the CCG funding the Section 117 aftercare?
Yeah, I mean, that, you know, those are about local arrangements. I remember when I first started doing this work, and I thought to myself, having come from, you know, a background with mental health, thinking, oh, you know, Section 117, it's very clear what it says. But actually, there's been lots of very geographical, local arrangements and agreements around how Section 117 aftercare is provided. So in one area, you'll find that the CCG has basically kept the whole budget themselves, and they manage that, and they will commission services from the trust and or from the local authority that are very specific. And so that's pretty easy and straightforward. And then you'll find that there are places across the country where the CCG basically cannot locate their Section 117 budget because historically money has gone to the local authority and arrangements have been put in place. Sometimes there's a Section 75 agreement in place, sometimes there isn't. It's just an informal arrangement with a local authority that they would provide Section 117 aftercare for people who are living in the community. And then every provider, mental health provider trust, would be expected to provide Section 117 aftercare services, but often that's, you know, that's bound up with all kinds of, you know, recovery college provision, day centre provision, initiatives that, you know, local trusts provide that would be free for people who are Section 117 eligible, and there'd be a payment required from people who aren't. So it's a very, I said from the start, it's a very complex set of arrangements.
And that's certainly what we've heard from advocates, Janet, as we've been kind of going through these sessions and preparing and asking advocates what do they really want to know. I think people's experiences are that it varies so different locally that advocates start to question the guidance and question whether they're interpreting it correctly. But actually, there's really wide interpretation of the guidance, isn't there? And things do operate differently in different areas. Should we do one more question before we move on?
I mean, the one thing I would say about personal health budgets, and that's in any setting, and particularly in Section 117 aftercare, is that what it does is it highlights where the problems are, and that what we recommend is that you work with the individual. You know, a key element of a personal health budget is the personalised care and support plan. And that's about talking to people about what matters to them, what are the things that are going to help them to get better and be as well as they can be in the community. And the right to have enables a push for that conversation. And it may be that, you know, that you can have a notional personal health budget, which where people are on, you know, much more complex care packages, often that's what happens. The person's, has explained to them what's on offered, and they just decide how they utilise what's already being offered by the NHS. We find that with people where there are capacity concerns, that's one of the options that often happens, is that people either have a notional budget or they have that combined with a third party budget rather than having a direct payment. But it enables a much more personalised conversation to take place in a way that, we could have picked anything in mental health. It's just that Section 117 Aftercare, like I said earlier, it's really clear about eligibility, so who is eligible to have it. It's a starting point, I think, for people.
So that bit about direct payments, Janet, this last question kind of links back to that, and somebody's asking if the person's 117 Aftercare is being arranged by the local authority, would they get a direct payment through the local authority rather than a personal health budget?
Well, the idea is, this is where we get to, a lot of our conversations these days tend to focus on integrated budgets. So as far as we're concerned, that, that work ideally should be taking place, behind the scenes between the local authority and the health provider. A lot of places will have already joint Section 117 panels where all of the local authority, personal budget work is coming to. So people will be used to going to panels that are talking about, personal budgets within the local authority unit. And what we would anticipate seeing is that that's the place where people would also, start talking about, personal health budgets. And a lot of places will tell us that they already offer 50-50, contributions of funding. They just go down the line, and everybody that comes to panel, they offer 50-50 funding. And so within that, we'd expect them to be, talking about, the needs that a person has as a whole. The whole point of, the key element of a personal health budget, which is the personalised care and support plan, is that you talk about, that person and with that person in a very holistic way about what will help them.
Absolutely.
And it will be for local. I think that's what's happened in City and Hackney. Is initially it started off as being a very separate offer, but now there's more conversations with the local authority, and I know that's what's also happening in Birmingham as they started. Because Birmingham, they're not an integrated local authority and mental health provider, so their mental health provider is just a trust, a mental health trust. But now they have started to take their personal health budget, personalised care and support plans through that integrated panel and started to have those conversations. But I know it's very early days for these conversations.
We'll let you get on. I'm mindful of the time. There will be more questions and more opportunity for questions as we go through, but I would love for you both to be able to cover your prepared slides. So I'm going to turn myself off.
Okay. Do you want to move the slides on, Bonnie?
Yeah, my keyboard keeps falling asleep after has been not useful. So bear with me.
The question here, just whilst we're waiting for it, was: would someone who was under Section 3 5 years ago be eligible for Section 117 Aftercare? And the answer is yes. If somebody's been detained under Section 3 at any point, they're eligible for Section 117 Aftercare. And if they have not been formally removed from Section 117 Aftercare, then they're still eligible. So I'm falling over my words. So this link here at the very top, the underlying bits are the link. So if you click on this, it should take you through to the right to have guidance for personal health budgets and personal wheelchair budgets. But we're focused on Section 117 Aftercare specific. So this covers all of 4 of the areas where there's a right to have, but then through it will identify specific bits that refer to Section 117 Aftercare. But obviously it starts out just by talking about personal health budgets on page 7, and describes personal health budgets as an amount of money to support a person's identified health and well-being needs, planned and agreed between the person, their representative. So, the person can have people present to help them to develop their personalised care and support plan, And in the case of children, families and carers would always be involved as well. And then obviously the local NHS team. Now here it says it's not new money, but money that would normally have been spent by the NHS on a person's care, which is true, but the dialogue is changing over time, where there is transformation funding coming into mental health services. So there's a number of sites where they are building into their forward transformation plans a small pot of money to be held for personal health budgets. I think that again is something that's happening in Hackney, Bonnie.
Yeah, it started as a pilot, and now it's going to be part of the recurring funding.
And basically the personal health budget is kind of that. I think when my colleagues came, they probably explained to you the whole personalised care model, with the personal health budget being the culmination of every element of that model. This person will have been on a bit of a journey already and will have had a personalised care and support plan. You cannot have a personal health budget without having had that what matters to me conversation with the person and their family and whoever else you feel is relevant and pertinent to involve. So 3.1 will talk about personalised care and support planning in detail, because it's absolutely crucial and key. And then you've got 3.2 where it talks about managing the PHB and reviewing the PHB, and that will apply across section 117 aftercare and all the other right to haves as well. Move it on, Bonnie. Thank you. And this is just the more detailed, more technical explanation of eligibility for section 117 aftercare. So the explanatory memorandum that went alongside the right to have. So 4.2, if you want to look at the document itself. But it's just to be clear that, you know, these are the sections that make somebody automatically eligible for section 117 aftercare. And then if you look at the bottom, it just clarifies that, you know, for people who have been detained under section 3 and then discharged on a community treatment order, people who have been detained under section 3 or one of the forensic sections and are granted leave of absence under section 17 leave, and or patients who are restricted and on a conditional discharge, often referred to as section 3741 patients, would all be eligible automatically for section 117 aftercare. If you can move that on, Bonnie. I just wanted to, all of this is massively complex, and when, you know, I think I'm giving you an overview and I hope resources that will help you kind of think it through, but it's all very much focused on, you know, the individual and working with that individual. And, you know, you are going to have to do some breaking down of some of the rights that people have in order to, you know, make sure that you've got it correct. So I'm hoping this slide is helpful. So rights to an IMHA, for example, would apply in these particular situations. So when you are detained under the Mental Health Act, when you are liable to be detained, so there might be people absent without leave from hospital where papers have been completed, where you're subject to a community treatment order, subject to guardianship, where you're conditionally a conditionally discharged restricted patient, or where you're a voluntary or informal patient, and these kind of treatments are being considered for you. So that's when you have a right to an IMHA. And if you could just press the right to a PHB are in these circumstances. So it's just really pulling together some of that information from before. And as I was looking at this today, having just got back and having done these before I went on leave and got sick, I was just thinking that it might be, you know, this might be right for a lovely little chart or something. So if people would find that helpful, let me know, and I'll try and do something like that, just to try and make it really clear about when the right to have applies. If you could move it on, thank you. So 4.2 of the right to have guidance. So whenever I'm referring to these, I've got 4.2 up in the corner, or a number up in the corner, I'm still referring to the right to have guidance. We'll tell you when the right to have a PHB applies. So it's basically whenever planning is taking place for section 117 aftercare needs during an admission to hospital, and that might be, the first time somebody's been detained under section 3, so it should be considered at that point, or it could be somebody that's been readmitted, and it should be considered at that point. And at any assessment held to review the person's Section 117 aftercare package of support in the community, people who are Section 117 aftercare supported will have regular reviews in the community. And I'm not going to commit myself to saying how often those should be, because what should be and what is often don't make sense. But whenever there is a review, that's a point at which you should be advocating for somebody to be considered for a personal health budget. And really importantly, it will include care and treatment reviews for adults, or care, education and treatment reviews for children who have a learning disability and or people who are fall within the spectrum of autism. So there are people, there's an overrepresentation within mental health stats, which you're probably aware of already, for people with a learning disability and or who are autistic. And if they're going down another pathway, which is about care and treatment reviews rather than maybe Mental Health Act processes, they should also, they also have the right to be considered for a PHB. You could just move that on. So I digress slightly here, because there's a very important position statement that came out recently. I don't know if people are aware, but there's been a lot of there's been a massive programme around community mental health teams, where they are expected nationally to propose and implement a massive transformation programme, and are being expected to make the way that community mental health teams work within the community much more personalised, holistic and responsive to individual needs. And on the back of that, recently, this CPA position statement came out from the NHSE mental health team, indicating that the expectation is that care programme approach processes will be replaced with high quality, co-produced, holistic, personalised care and support planning for people with severe mental health problems living in the community. So the expectation is that we will move away from care programme approach within hospital planning for discharge and moving into personalised care and support planning, which obviously links beautifully with the offer of spending the budget in a different way that's more creative and more in line with what's going to meet that person's needs. The only exception to that are for people who are within prisons, where CPA will remain. And I'll talk a little bit about that a bit later on. You can move it on, please. So back to the right to have guidance, I just wanted to flag that there are some specific considerations. When we revised the right to have guidance, we met with a wide range of voluntary sector organisations, mental health provider trusts, the LGA, ADAS, and we made sure that we covered off some of the difficult areas. So people with no recourse to public funds are often people that end up in hospital for months on end, and I no doubt you've been involved in the going backwards and forwards, and this just provides some guidance which around the legal position that they find themselves in, and that basically if they are if they're detained in hospital, then that supersedes the regulations about not having recourse to public funds, and they are eligible for Section 117 aftercare. And then there's also just this consideration for children and young people who are in transition. So I don't want to go into detail about that because it will take us off, but I just wanted you to be aware of it. If you can just move it on, Bonnie. So when preparing to provide personal health budgets, and PWBs are personal wheelchair budgets, the CCG should ensure that all people who become Section 117 section eligible are advised of their rights under Section 117, including the right to have a personal health budget. Now, I know that's probably unlikely to be happening in large, swathes across the country, and that is one of the key things that we're hoping to change over the next year. Obviously, during the COVID period, there have been other priorities to focus on, so a lot of the work embedding how this might happen hasn't taken place. But over the next year and moving forward, we anticipate, doing more and more of that work. And it's really, what's really important to be clear about is that the personal health budgets don't alter NHS eligibility or the way that CCGs currently manage services. So only people who are eligible to receive NHS services will be able to have a personal health budget. You have to have a health need in order to get a health budget. And that brings us back to the discussion with social care, which we would hope that people would end up having just sensible conversations about behind the scenes. But the CCG would also need to be satisfied that the benefit to the individual of having a personal health budget, and or if they go for a direct payment, represents value for money. So it can't cost more, and that the healthcare delivered via the personal health budget will provide the same or improved outcomes as traditionally commissioned care. And that should all be in the personalised care and support plan. It should very clearly explain why what you're asking for is being asked for, and it wouldn't be available elsewhere, or what's available elsewhere wouldn't meet this person's needs because of, and the health needs that are going to be met should be really clearly explained in the personalised care and support plan. And I've just put in here a link to the guidance on direct payments for healthcare, because that's also really helpful if you are involved with an individual. There's a lot of useful advice in there about, and especially if they do want a direct payment. But like I said, there's three ways of paying, so it's not just getting stuck on direct payments. Sorry, Bonnie, making you going backwards and forwards. So in section 7 of the guidance, when should they be provided? So basically, if a person comes within the scope of the right to have, so if they're section 117 aftercare eligible, then the expectation, and it makes sense for the, in terms of financial sense, and it makes sense in terms of that person's health outcomes, then the expectation is that one will be provided. And it is very clearly saying here that it would be exceptional circumstances where a CCG considers the personal health budget to be impracticable or inappropriate. Now, I know that's not the situation that we're in currently. That's the situation that I suppose we hope to get to. But there is also this issue that comes up really regularly about if you're doing a personalised care and support plan and you're working with the person on what matters to them, this issue of capacity. And we do a separate presentation where we go through the Mental Capacity Act and the application of the Mental Capacity Act in this situation, in the same way as you would if you're working with anybody where there are capacity issues. You would assume capacity, and then it would be decision specific focus around, what can this person make decisions about, how can they be best helped, etc. And it should never be assumed that people with a learning disability lack mental capacity. And we have had people within services say that to us previously, is that, a person can't participate in personalised care and support planning and what matters to me conversation because they lack mental capacity. But it's very, the capacity test must be applied to each decision the person's being asked to make. And it very strongly says that, obviously, within this guidance. So if you ever need some guidance to support what you're saying, it is in there. If you could move it on, please. So this is the bit where, if you need to challenge. So section 7 of the right to have guidance says very clearly that if a person requests a personal health budget and is turned down, then the CCG must set out in writing the reasons why the request has been refused. And then once that's been received, the person and or their representative can ask the CCG to reconsider the decision and provide additional information relevant to that decision. And then the CCG must reconsider its decision upon such a request being made. And in the document here, it does also suggest a good practice time frame for, how long the CCG should take to respond to challenges about a personal health budget. And then you can see section 7.2, deciding not to provide a direct payment. There are instances in which, if you look at the direct payment regulations for healthcare, there's a particular piece about people who have substance misuse issues and direct payments. And there is some guidance there about, if somebody's under certain parts of the Criminal Justice Act, you know, they shouldn't receive a direct payment. So, but that's in the guidance session, the link I provided a bit earlier. And then if they decide not to agree some elements of the personalised care and support plan, or if they decide to delay the start of a PHP, which does happen often. Obviously, the personalised care and support planning can take some time and should take some time, because you're talking to that person about what matters to them. And in that time, sometimes people do become unwell. And so there are sometimes good reasons for delaying the start of the personal health budget offer in those instances. And that's certainly been the case in Birmingham and City and Hackney sometimes, where somebody's maybe gone back into hospital and then, you know, the PHB's been revisited and started when they come back out. If you could move on, Bonnie. So I'm not going to go into this, but this is the bit where I said we'd come back to the prison population. You know, it's impractical at the moment to provide a personal health budget for all kinds of reasons. You know, there's all the security issues within prisons. You know, it's hard to genuinely have a what matters to me conversation and then provide the range of things that a person might want within custodial settings. But what the guidance does say very clearly at the end is that CCG should ensure that people who are entitled to Section 117 aftercare, who have been released from prison, should not be excluded from having a personal health budget. And I know that there's people in those situations that have come into the community, and City and Hackney have worked with them to provide a PHB.
Yeah, we've got a few examples. So we've got some people that have maybe used a PHB following prison to sort of join a course or training to support with kind of returning to employment. And then we've got another person that's got a personal health budget at the moment, who had been using the gym in prison to sort of support with managing difficult emotions and negative thoughts. So when he kind of returned to the community, he thought it'd be helpful to kind of have a gym membership so that he can continue sort of that management of emotions. And he actually picked a gym that he could access 24 hours a day, because he found that it was either really late at night or kind of early hours in the morning that he had the negative thoughts. So that was, you know, the perfect time for him to then go and access the gym as well. And so with his team, they kind of found the gym that was most suitable for him.
Thanks, Bonnie. So that if you want to move that on, I think we've got to the end of the right to have guidance section. I can see there's one question about who's generally in charge of the Section 117 list. Well, I don't. However many ICSs there now are in the country, that's probably how many different people are in charge of the Section 117 list. You know, basically, when we ask people to go and pull their lists together, we always recommend that they go and talk to, you know, their local authority, because often they'll have a list there. A lot of the local authority sites will have flagged up people who are Section 117 eligible. That they talk to the CCG, and that they go and talk specifically to the Mental Health Act office within the provider trust, because that's where all of the, you know, Mental Health Act papers will have been submitted over years. And so, you know, that's an obvious place where they'll have loads of, you know, all the accurate information about people that have been detained and under which section they've been detained. But it can be very laborious, as you can imagine. Okay, so when we, in a moment, I think we're going to move on to some case examples, which I hope might give you an idea of, you know, how PHB's been implemented in practice. And I can't see what that question says. Should a social worker be jointly responsible in supporting a person to create a care and support plan? Yeah. I mean, you know, in City and Hackney, they work, the Voluntary Sector Alliance work in partnership with East London Foundation Trust, which has, you know, social workers integrated within their mental health teams. And so it's a whole range of teams and providers who undertake the personalised care and support planning. So it can be OTs, it can be social workers, nurses, you know, voluntary sector members of staff, and, you know, a huge range of teams, isn't there, that undertake that personalised care and support planning. I think there are mixed results in terms of who's best, but we'll talk a little bit about some of the learning from that and some of the common frustrations as we move on.
And Bonnie, someone's got their hand up. So Vicky, I don't know whether you had a question that you wanted to ask, so we'll unmute you or make it possible so that you can ask a question. I don't know whether you had something you wanted to check in with Janet and Bonnie about.
Yeah, whilst we're waiting for the unmuting, there's a question here about if a mental capacity assessment finds the person lacks capacity to manage a PHP, can someone manage it on their behalf? And the answer is yes, and we would promote that, absolutely. You know, you should, with any practice, it's not just about the PHP. If you're looking to engage, you know, people who are able to support that person in the community, you know, with their permission. And yes, you can have a third-party payment through an organisation, and you can also have a trusted family member who can manage the PHP on their behalf.
Yeah, I guess that's an important part of the sort of planning of a PHP and what's sort of considered when planning the PHP, kind of how that can work best for the person.
I think maybe Vicky's hand might have gone up by mistake. So Vicky, if there's something you want to say later on, come back in. But Janet and Bonnie, I'll turn myself back off so you can finish off with your example. Yeah.
So if we could move on to the next section, we might answer the next question as well, which is about PHPs in practice. So this bit's focused very much on some case studies. We've got some lovely videos and case studies which on our website, which I'll show you at the end, or when you get it you'll see it's at the end, you know, how you can access our website. But here we've put in a few. I'm going to hand over to Bonnie, I think, to talk about the City and Hackney offer.
Yes, so so just to kind of give you a bit of background to City and Hackney PHBs and like some of the people that we work with. I actually work for a charity called the Advocacy Project, and we're commissioned by City and Hackney CCG to deliver the personal health budget service in City and Hackney as part of the mental health recovery pathway. And the reason that it's commissioned was that our commissioners noticed that a lot of people were sort of, as they called it, sort of stuck in secondary care, mental health services. So they wanted to look at how maybe sort of they could do things differently to support people to actually move along their sort of recovery journey. So that the service is available to adults who are residents of City and Hackney and are receiving support from the local NHS Trust, which is East London Foundation Trust, and that they're receiving support for a severe and enduring mental health condition. And the PHB is there to support a person to work towards a recovery-related goal and step down on their recovery journey to sort of self-management of their mental health. And that could be either in kind of one step or a series of sort of small steps as well. So during a planning meeting between the person and their clinician around what will help the person to be well and stay well, a personal health budget can be considered as one of the options for supporting someone to achieve their mental health recovery goal. So the personal health budget doesn't sort of replace any existing services, but it creates kind of more choice for the person so they can work towards, you know, their goals in a way that works for them. And I guess me and my team are there kind of along the way to support the clinician and the person with kind of planning that PHB. Sometimes we might join them, you know, in a conversation and have a three-person conversation to help with that planning of the personal health budget. And we also kind of train clinicians in kind of thinking about personal health budgets and thinking in that kind of personalised way to think about how that person can use a personal health budget to sort of be well and stay well. And we use that phrase a lot when we're kind of in our training or presenting what helps me to be well and stay well. So in City and Hackney, our budgets are kind of a relatively small kind of monetary value, but obviously can have, you know, a big impact for the person. But kind of in sort of May we looked at kind of our average price and found that generally on average people's budgets were coming out around £277. And as we sort of mentioned already, because the the PHB is offered as part of the mental health recovery pathway, 41% of people that have a personal health budget are on a Section 117. So I've picked a couple of case stories to just go through from our service, a couple of our budget holders. We have, a lot of examples and stuff, and I think that's like the best way to talk about PHBs and to train staff is to use kind of case examples. So if anyone has any questions or kind of wants any more examples afterwards, you can contact me. So first of all, we have Jenny. So Jenny's 30. She was discharged from hospital into the care of the community mental health team. Her team has said that she's made a lot of progress in her new accommodation, but sort of lacks some confidence and can find it difficult to carry out some tasks day to day, sort of independently. And she can find it difficult at times to kind of communicate to sort of support the communication, and they wrote down ideas in a way that worked for Jenny and would help her to sort of remember the conversation after it's happened. And they talked about what's really important to Jenny. So Jenny explained that she loves painting, so she paints flowers to decorate her flat at home, and she feels particularly relaxed when she's painting. She said for her it would be really great to make some new friends to do things with. She doesn't currently have that many people around her. So Jenny and her care coordinator planned a PHB to access a local arts organisation called Core Arts for people experiencing mental health difficulties. And both of them thought that this would give Jenny an opportunity to meet some new people in an environment that she felt supported and doing something that she enjoys and helps her to feel relaxed. So for Jenny, it worked out best for the classes to be purchased using a notional PHB, and this meant that Jenny didn't have to manage the budget herself. And they also planned that Jenny's support worker, who she gets through a personal budget, would attend the classes with her while she kind of gains confidence. And then, so for 6 weeks, so we kind of do a review at 6 weeks and then at 12 weeks. So the feedback we had at the 12-week review, which I think was a couple of weeks ago, Jenny said, "I love it. I feel happy, excited and lucky to be going to Core Arts. I love the painting and drawing the most. I've made one new friend and found an old friend from school again. I'd like to meet up with in the park soon and maybe go to the cinema." And sort of Jenny and her team are at the moment sort of working towards sort of her going along to Core Arts independently, now that she's sort of met some other people and sort of growing in confidence. And the second person we have is Sam. So Sam is 41 and he received a warning from his housing manager as he damaged some of the items in his room. Sam's care coordinator sort of talked to him about this and asked him, what had happened. And he explained that, whilst they're generally managed well, when he becomes particularly stressed, the voices in his head get worse. And he calls this the pressure in his head. When the pressure is particularly bad, he feels the need to kick or punch something. And through doing this, he experiences a release and the voices go away again. So this is obviously what had happened in Sam's room. So Sam's accommodation is really important to him and it helps him to feel safe. And the idea of losing the accommodation makes him feel very anxious. And obviously when he's anxious and stressed, the voices are worse. Sam and his care coordinator sort of planned what was important to Sam and what would help him to be well and stay well. And Sam said that he wanted to find a way to manage the voices in a safe way so that his tenancy wasn't at risk. And they decided that Sam would use a PHB through a direct payment to purchase a freestanding punch bag that he could use within his room to kick and punch when he feels the pressure in his head. Sam had previously practiced martial arts until he sort of retired due to injury. So the punch bag is something he feels really comfortable using and familiar with. And he also talked about being able to use it to support his sort of physical health as well. Sam isn't very confident online, so he asked for a prepaid card to be loaded with the budget amount, and this prepaid card could be used as with any debit card in shops and things. So he could then actually go into the shop with the support of the care coordinator and purchase the item in person. So at the 12-week sort of review, Sam said, "It helped when I feel stressed and feel pressure in my head from the voice. The pressure builds up and then I can punch the bag. It helps to release the pressure and the voice subsides." So as well, at the sort of point of, well, at the first point of referral, then at the review and closure, we do kind of an impact questionnaire, and we use this to measure kind of the impact of personal health budgets. And for Sam, his impact scores had improved quite significantly from before he had the PHB to afterwards. And he's actually starting to plan, so he had the punch bag a little while ago, and he's starting to plan the sort of next stage, and he's planning a future PHB with his team. And he wants to, his plan is to feel kind of less isolated, and he'd like to spend more time out of his room. And he said that when I'm busy and in the company of other people, I don't experience the voice that makes me feel stressed and gives pressure in my head. So he wants to use a PHB to support him to kind of get out and meet new people in the community. So yeah, there's a couple of our examples.
Thanks, Bonnie. I don't know if you just want to move the slides on just to show people. There's a couple of, I'm not going to go through these because I'm just really aware of time and we want to get onto some common frustrations, but this is from another personal health budget offer in Thameside and Glossop, where they work specifically with people who are a long stay in hospital or residential accommodation. So that kind of really high-end group of people. It's just one person's story. And then if you move it on, there's also an example from Birmingham where they offer PHBs to people who are Section 117 aftercare eligible in their community mental health pathways, and have recently expanded that offer into their hospital settings. This is an example of Len, and it does focus very much on the view of Len and his capacity issues, and how that kind of more personalised conversation with the offer of a budget if he needed it helped him to meet his needs and improve his situation. So if you could move through those, Bonnie, I think we'll just move on to the next lot of slides. I just noticed there's a question about the average budget for what period. How long a period is that, Bonnie?
Yeah, so the personal health budget, some people, so people can use their personal health budget in City and Hackney for up to a year. So if, say, they had decided to use a personal health budget for a gym membership, they would be able to have that membership for kind of up to the year. Obviously, a lot of people might use their PHB for a piece of equipment. In Sam's example, the punch bag, or it could be kind of a digital device like a laptop. Obviously, for those people, they have that's their item for them to keep beyond that point. In terms of kind of, so how long we kind of will kind of oversee the PHB. So it's normally for sort of a period of 12 weeks. So at the 6-week point, we'll do a review, and then we'll do a closure at 12 weeks. Obviously, if there's a reason that kind of the period needs to be longer than that, perhaps someone was kind of slow to access their budget, or it might be that there's further things that need to be considered around the PHB. It might be a bit longer than that, but generally it's sort of 12 weeks that their case will be open for.
We move on to the next slide, because I think what I should point out here is that City and Hackney's offer is pretty exceptional nationally. And one of the key problems and common frustrations for people who are trying to access a PHB on behalf of somebody is the lack of knowledge and information right across NHS staff about the right to have a personal health budget for people, and about personal health budgets more generally, I would say. An increased lack of knowledge then across partner organisations, because as NHS England, our focus has very much been on clinical commissioning groups, CCGs, and it's within the CCG probably is the most knowledge, or should be the most knowledge, about personalisation and personal health budgets, because there should be a personalised care lead within the CCG. But obviously within local authority and voluntary sector organisations, we've only started really that process of having the conversation about the right to have and about personal health budgets, and how we might look at integrating budgets with local authorities. The other common frustration is just that the local arrangements. I mean, it can be really hard to locate a list, an up-to-date list, and funding that goes with that. So there are a lot of places where they focus very much on their complex people, because often that's a budget that is either held or co-held by the CCG, and is more easily accessible. And so they'll be looking at people who are in very complex situations because they know they've got money attached to that person, or it's very unusual to have an offer within the recovery pathway, as Hackney have based theirs. So yeah, people who might be eligible for the right to have, and their carers and friends, family, just simply not knowing that, one, they're Section 117 Aftercare eligible, and two, not knowing that they're eligible under a right to have for a personal health budget. So it can be difficult to identify those people. Understanding what makes an integrated personal budget, like there'll be places where they'll say, oh, we do 50-50 funding, that's an integrated budget. And what we'll say is, have you got a personalised care and support plan that focuses on what matters to the person? And often you'll find that the key elements of a personal health budget just aren't in place to enable us to call that an integrated personal budget. Current funding streams and finance or different solutions for people, it's a fight to get the finance people on board often, and engaged in making payments in the different ways that they need to be able to do it, in order to personalise services more. Just how small the group is. If you just move on to the next slide, Bonnie. I mean, these are some of the sites that we've worked with and we know are either offering personal health budgets or looking to develop personal health budget offers. And to the right-hand side, you can see the different pathways that those sites, are offering. So this is the pathway they're offering it in. So it's not even necessary that they're offering it across the whole of their mental health services. So you as advocates would need to be seeking access to the right people, and asking the right questions. And as I said, it's going to be very much on an individual basis, and we're happy to be contacted about that. If you could just move it on. This is we did a programme focused on children and young people's mental health sites, because particularly that transition group, and that focus that there is currently in mental health on the 0 to 25 nature of the children and young people services. So a lot of sites engaged with that, and almost all of these sites have managed to develop even a very small personal health budget offer in the pathway as identified on the right hand side. But these are examples more than they are common practice, for sure. If you could just move on to that. There's a second common frustration slide, which is much more focused on, some of the things that, Bonnie would recognise, which staff who are fearful, either they, you know, initially feel a perceived threat to their role, because if we're letting people do, you know, manage their own mental health needs in different ways, then obviously there's potentially, you know, a loss to the workforce, perceived. And then also this issue about perceived risks to the person and, you know, to the organisation if somebody, you know, goes off and spends the money on a, I don't know, trip to Magaluf or something. Staff who are not trained in personalised care and support planning, and how you set an outcome that identifies the health need and clearly explains why, you know, that person's health need can be better addressed in this different way. You know, people really struggle with explaining that sometimes, and therefore don't get funding for people. And often staff who are unable to hold a conversation that focus on what matters to me. You know, staff, I mean, I'm a mental health social worker myself, and, you know, often it's trained out of you within services because you're always asked to focus on what the computer system wants you to focus on, you know, and struggle then to actually open up that conversation and think about wider things. And sometimes that's because people are fearful that, you know, they'll open up Pandora's box and the person will ask for something and they won't be able to provide it, you know, but they know very clearly that there is a budget available and they know kind of what that budget is around about. It just frees up the conversation with people beautifully. And then there's this thing about, you know, the way that services run at the moment, a lack of time to hold those proper what matters to me conversations with people, apparently even when detained in hospital, which I always find a bit shocking. You know, if somebody's in hospital 24 hours a day, you think, and some of our loveliest personal health budget offers have come from somebody in a hospital who just knows how to have a conversation with somebody about what's important to them, and, you know, has led to their needs being met through a whole package of care that's very different. And then, you know, the myths that go around that people will misuse the money. Hackney have a lovely report on misuse of funds for their, what was it, 742 budgets, about 19 cases of misuse of funds.
Yeah, about 5%. Yeah.
And a number of those were because, you know, people didn't have it properly explained to them in the first place, that they had to use it for this particular thing and couldn't use it for this thing, even though this thing's more of a bargain. So there's lots and lots of common frustrations that we try to address by going out and talking to sites, you know, and it's frustrating for staff there. I just wanted to show you the next slide, which was one of the case studies from I think the National Development Team for Inclusion report I talked to you about earlier. It's one of Hackney's studies, which is now used as a training tool. Is that right, Bonnie, for how not to do personalised care and support planning conversations?
Yeah. So yeah, we always use this one in training because it's really important to show, I guess, what the outcome can be if a person isn't involved in the decision making, and, you know, if they aren't asked, you know, what's important to them. So yeah, this is Kai, who had a personal health budget, and he was asked to kind of share his experience of the PHB. And what he said was, you know, I don't have a mental health problem. They mess up your head with medication. My care coordinator said the PHB is for activities to keep you occupied, but they didn't give me what I wanted. My choice was a FIFA game, but they chose a cinema card. It was done online and I haven't used it. It's annoying because the FIFA game would fill time at home and help with my negative thoughts. I didn't ask for the PHB, but it seems they didn't want to give me my choice or let me have the money. PHBs are a good idea, better than medication, but people should decide how they spend it themselves. So obviously with this example, you know, Kai was really clear around and knew himself what would sort of help him to be well and stay well. And that was the kind of video game that would help him to distract from the negative thoughts. But he wasn't, you know, that planning didn't happen, you know, with him, or certainly not enough. So he ended up having an item that he didn't use, and also kind of feeling that he wasn't listened to either. So yeah, this is an example that gets shown a lot, around kind of sort of asking the person, you know, what's important to them, and then supporting them to plan kind of what will help them to be well and stay well. And I think that there are, you know, in some cases there can be, you know, members of staff that find that uneasy, having that conversation and asking the person those questions. I guess that's kind of part of what we do in terms of our training. We kind of try and support around that. And I think in terms of risk, one of the things that we sort of did was develop some resources around how a member of staff or a clinician can have a conversation with someone around potential risks, because we don't want any risks to be a barrier to someone receiving a PhD. We want them to kind of positively risk assess, put a plan in place so that where possible those risks can be mitigated and the person can use their PhD kind of as they need to support their well-being.
Thanks, Bonnie. Can you just move the slides? And I'm not gonna I mean, basically this is practical advice, tools and support from us. And if you just go, this is a link which will take you to the Future NHS Collaborative platform, and you'll have to register, but basically it will take you through to all the resources that we've got. We also have this national community of practice, which if you basically just go on, I mean, the next one is on Tuesday the 21st of September, working out the money, 10 till 11:30, and literally if you click on that working out the money on that morning at 10 o'clock or just before, you can join a session where our mentors talk through how they have developed that, the budget setting and decided on how much money and then how they manage that process and some of the difficulties and experiences they've had around that. And then there's a session where we go into small groups and people get a chance to ask questions and so on. And then November's exactly the same, but it's making a care plan. So you're very welcome to join these sessions. And then the other slides I'm just going to skip through, Bonnie, if that's all right, because this is just the collaborative and it just shows you how to access it. Obviously you can do that in your own time if you want to just go through them. We'll get to the end. Yes, it just shows you how you get onto it. And then just the last slide there is again links to some of the main resources that we've talked about today, in case the ones in the slides don't work for some reason, so you can copy and paste these. And then I think we're at the end finally.
Yeah, I think there's a QR code there, so you can share your feedback using the QR code. Is that right, Gail?
It is right. Thank you so much, Bonnie. Yeah, we'll send out, when we send out the copies of the slides, we'll also send out the link to the feedback form for the session. I know we're slightly over time. Thank you so much, Janet and Bonnie. That was just so helpful. And I think kind of it's really well timed in the kind of running order of the conversations and the webinars that we've had over the course of the summer. We had a session on kind of how to have that good conversation and thinking about outcomes a few weeks back. So just a reminder to people that all of the recordings from the sessions will be available at the point that we kind of launch the overall training hub in relation to advocacy and these health funding processes. Did anybody have any last questions while we've got Janet and Bonnie before we let them go? I think somebody was asking Bonnie to understand the context of your City and Hackney project. Where did that come from?
Yeah, so in City and Hackney, the Commission has kind of noticed that there were a lot of people that had been under sort of secondary care mental health services for a very long time, and that were they kind of use the term stuck within secondary care mental health services. So they kind of wanted to explore what they could do differently to support people kind of on their recovery journey and to kind of move on. And I guess one of the, they then looked into the personal health budget, which is, about kind of looking at what that individual person needs to support with their well-being and their ongoing recovery, and doing it in a way that kind of is unique to them. So it started off as a pilot service in June 2019, and they kind of looked at the impact of it, and kind of when we look at the impact of the outcomes fairly recently, it was sort of 67% of people had kind of improved scores after having their PHB. And if you kind of broke it down into particular areas, sort of, I think it's around 78% of people felt as able or more able to cope. 80% people felt as happy or happier. So, you know, from looking at kind of the impact, you know, it's now been being kind of commissioned as part of their kind of reoccurring funding now.
Thanks, Bonnie. So yeah, just to clarify, we will send the slides out. I know people are asking, and that some people have put some extra email addresses in the chat. So I think we should be able to access those after we're off the call. But if you haven't got the slides, you know, in a few weeks, and then get in touch with Kate or I, and we'll make sure you can access them.